Show their dark side, a weakening tale. Our case is about a 70-year-old male with a history of hyperlipidemia, treated with atorvastatin and OSA on CPAP, who presented with 1 month history of progressive proximal lower extremity weakness, myalgias, and difficulty walking. His symptoms initially began following a fall about a month prior and progressively worsened to the point where he could no longer walk safely. He states that his only recent changes in his medical care include the addition of atorvastatin roughly 2 months prior to treat his hyperlipidemia. He denied any other symptoms and had no prior history of similar episodes. His physical exam was remarkable for bilateral lower extremity proximal weakness, including 2 out of 5 muscular strength in the proximal muscles and 5 out of 5 intact strength in his upper extremities. No focal neurological deficits were noted. In the ED, a CT lumbar and thoracic spine were unrevealing, only showing multi-level spondylosis and facet arthrosis. Workup at the time included a differential diagnosis including polymyositis, dermatomyositis, critical illness myopathy, spinal canal stenosis, myasthenia gravis, GVS, or statin-induced myopathy. However, the relation between the initiation of atorvastatin and the onset of this patient's symptoms prompted laboratory workup, which ultimately revealed a positive anti-HMG-CR antibody. Given this finding, a muscle biopsy was performed on the left vastus lateralis muscle, which ultimately revealed necrotizing myopathy with minimal inflammation, characterized by type 1 myofiber predominance and central core-like reactivity, absence in NADH staining. The muscle biopsy findings, along with the clinical and serological presentation, confirmed his diagnosis of immune-mediated necrotizing myositis. This condition is often associated with specific antibodies, including anti-SRP and anti-HMG-CR. Given the severity of this patient's symptoms and positive antibodies, he was started on corticosteroids as well as IVIG, which led to improvement in his proximal muscle weakness initially. However, during his hospital course, there was a complication of a DVT with a subsequent PE formation. As a result, his treatment regimen was ultimately adjusted to include corticosteroids, rituximab, and methotrexate to avoid the thromboembolic risks of IVIG. The patient's condition continued to improve with progressive recovery of muscle strength. Immune-mediated necrotizing myositis is a rare and severe subtype of idiopathic inflammatory myopathy. It is often associated with antibodies like anti-HMG-CR and anti-SRP. Early suspicion, diagnosis, and initiation of treatment, including immunosuppressive therapy, are crucial for patients to prevent long-term muscle impairment. The hallmark of the disease is the presence of proximal muscle weakness. Interestingly, interstitial lung disease occurs in roughly 10 to 20% of patients, specifically with anti-SRP myopathy, and in less than 5% of patients with anti-HMG-CR antibodies. Skin involvement can occur in up to 10% of patients. Autoantibody negative immune-mediated necrotizing myositis has been associated with a markedly increased risk of malignancy. However, anti-HMG-CR myopathy may have a relatively weak association with cancer. Treatment includes IVIG, corticosteroids, and immunosuppressive agents such as methotrexate or rituximab. In conclusion, this is a 70-year-old male presenting with rapidly progressive proximal lower extremity weakness and myalgias following a fall. His clinical course culminated in a diagnosis of immune-mediated necrotizing myositis with a positive anti-HMG-CR antibody. This case highlights the importance of timely diagnosis and aggressive treatment for immune-mediated necrotizing myositis, a condition characterized by severe muscle weakness and minimal inflammation, which can be associated at times with statin use.